Good afternoon to everybody. I'm Giuseppe Castellano from the University of Milan, Italy, and I would like to welcome all of you in this European Renal Association e-seminars on the topic on nutrition kidney disease. Today we have the pleasure to have Dr. Koppe, Laetitia Koppe from France, and Professor Bakker and Professor Davenport. And we will talk about how to optimize the nutritional care in patients with chronic kidney disease. So I would like to start with Dr. Koppe with his lecture. Please, Dr. Koppe.
Thank you so much. And dear chairmen, dear colleagues, I would like to thank the scientific committee for this kind invitation. And I am very happy to speak today about the nutrition in patients with CKD. So this is my conflict of interest, but I have not direct conflict of interest with this presentation. So the nutrition is in CKD could have an impact in different ways. First, nutrition could preventing the progression of CKD that we call nephroprotection, but also nutrition could preventing the complication associated with CKD, such as protein energy wasting or metabolic complication. I don't have the time to treat all this aspect, so I will focus about the role of the nutrition to preventing the progression of CKD. As you know, actually we have a lot of therapeutic strategy and new therapeutic that could give for a patient to preventing the degradation of GFR. But I think, and I try to convince you, that the nutrition could be additional or maybe synergic to the nephrotherapeutic strategy to improve the CKD condition in our patient. So the question of this e-seminar is how to optimize the nutrition care in patients with CKD. And I think there are three important points that we need to consider if we want to optimize the nutrition. First, I think we need to convince the patient, but also the scientific and the medical community about the benefit of nutrition for CKD patients. We need also have some specific renal dietitian, renal nutritionist to implement nutritional recommendation. And also we need to propose some food adapted for CKD patients. So I think it's a really challenge because in our society, actually, we have too many choices for the food. And for the question, what is the ideal diet for CKD patient? I think it's more and more complicated for the patient to apply the guidelines. So I think we need to support and to follow the patient to help them to choose the diet adapted for to prevent the CKD progression. So here I summarize the last guideline recommendation for nutrition. It's the Kaluki guidelines published 3 years ago, and they recommend to maintain an important energy intake around 25 kilocalories per kilo per day. They recommend to decrease the protein intake around 0.6 gram per kilo and maybe to decrease until 0.3 gram per kilo per day with a keto analog supplementation. They also recommend to increase fibers until 30 grams per day, to decrease potassium intake if we have some kalemia disorders, to reduce phosphorus and salt intake. So first of all, I would like just to focus about this recommendation. Here I summarize of various guidelines on nutrition in CKD patients about protein intake. As you can see, we have a trend to reduce the protein intake, and now we focus around 0.6 and maybe less, 0.3 gram kilo per day with keto analog. I think this recommendation, the debate is far from over, and the discussion about the reduction of protein is still criticized, and a lot of discussion about this point. I just select some Twitter, some scientific publication. that suggests the reduction of protein intake is not a main point and a main managed for CKD patients. I've not had the time to present all the data that lead to this recommendation, but I just want to open the discussion and show you some, for me, key studies that that are very important to propose this recommendation. And also, I would like to just show you some physiological hypothesis to explain why a low protein diet could be improve the CKD. So I just want to show you the old concept about the role of a protein to protect renal function. It's based on this old observation. When you increase protein intake, you increase your glomerular filtration rate. And we hypothesis if we reduce the protein intake, similar as we observe with using inhibitor of enzymes conversion inhibitor, you reduce intraglomerular pressure, you reduce glomerular filtration rate, and so you slow progression to CKD. But I think now we have other hypotheses and other mechanisms that could explain why reduction of a protein intake could be beneficial for CKD patients. The protein that you eat are metabolized by the gut, and especially by the gut microbiota. And the gut microbiota could metabolize the protein that you ate in different molecules, and these molecules are the precursor of a lot of uremic toxin. For example, the tryptophan, the tyrosine are the precursor of phenol, andol, and the phenol and andol are metabolism in pecresyl sulfate or endoxine sulfate, a very toxic uremic toxin and involved in the progression of CKD and cardiovascular complications. So we can hypothesize that the reduction of protein intake reduce the uremic syndrome and the production of uremic toxin. So I will give you some evidence by clinical study. First, about the link between GFR degradation and protein intake, I just want to show you this observational study. And this study measures the probability to be in dialysis depending the protein that you intake. And as you can see, there are clearly a linear correlation between the level of a protein that you intake and the probability to be in dialysis. And they measure the protein intake by two different ways, by 24 urine, by the urea, and also by the food record. And as you can see, by both methods, we observe the same association. Also, in this meta-analysis, the author select all the randomized control trial that compare low protein diet versus very low protein diet. And as you can see in this meta-analysis, there are clearly a positive signal in favor to reduce the protein intake to delay the dialysis. Of course, we can criticize the way of the study can be selected. We can criticize because majority of them are old, and probably a lot of patients are not under a modern therapy like glyphosate or inhibitor of angiotensin system. But at least we have a positive signal to decrease the probability to be in a dialysis with a low protein diet. About the role of the reduction of protein on uremic toxin, we are not a lot of data because it's just an emerging subject, but at least we have some clinical observations that suggest reduction of protein intake reduce the concentration of different uremic toxin. Here on the left, you can see when you eat 0.6 grams kilo per day of protein and you reduce to 0.3, clearly you see a decrease of the concentration of endoxine sulfate. Similarly, in this prospective randomized crossover control trial, you can see when you apply a free diet and you go to the very low protein diet, you have a reduction of endoxine sulfate plasmatic concentration, and also with the precresyl pecresyl sulfate concentration. And what is very interesting is when you apply a very low protein diet, you modify the composition of your gut microbiota. So it suggests that reduction of a protein could prevent the decrease of GFR, but also decrease the uremic toxin production by a reduction of the precursor, but also by the modulation of dysbiosis. Of course, all this study must be consolidated by over a larger study. So the second question that we have when we speak about reduction of protein is, what about the muscle mass? I just want to show you this picture. All these animals are vegetarian, and I don't think they have a problem of muscle mass. So what about patient with CKD patient? When we in this study, the author measurement the risk of the protein energy wasting, and they didn't see any difference of the risk of protein energy wasting, so the denutrition criteria, in patient under low protein diet versus patient on very low protein diet. In more recently, in randomized controlled trial, they measure the muscle mass by impedancemetry and the body fat mass under standard diet and under very low protein diet with ceto-analog supplementation. And as you can see, there are no difference between the muscle mass and the fat mass, and maybe at least a trend to an increase of the muscle mass. And we have some experimental data that demonstrate that the reduction of the protein is not associated with a huge increase of catabolism of muscle, because in this study, they measure the capacity of a muscle to recycle the amino acid under very low protein diet. And in very low protein diet, we have an increase of the capacity of a muscle to recycle the amino acid. So I think we have some evidence to see that there are a strong relation between GFR degradation and protein intake. And I think this sentence, the lower is better, is a good thing to propose for her patients. And also, if the calorie level are maintained, there are no risk of a denutrition. My next question is, the quality or the origin of the protein, is it really important for the nephroprotection? Because I just speak about reduction of protein, but the quality of protein, is it important? I have, for the moment, we don't have all the study to answer this question, but we have some study that give a signal that protein from animal is not the best choice, and probably protein from plants are better. For example, in this study, they measure the probability of survival in patients depending the quantity of red meat. And as you can see, the patient who eats more animal protein have a probability to be in dialysis more important. We don't know the mechanisms. Maybe it's only because we reduce the metabolic acidosis in patients who eat not a lot of red meat. And it will be also interesting to measure some uremic toxin level like TMAO to see if there are the link between the reduction of the red meat and the reduction of uremic toxin. Also, the quality and the quantity is really an important question. In our lab, we performed some experimental data about the composition of a protein, and we decrease only aromatico amino acid. It means only this precursor of the main uremic toxin, tryptophan, tyrosine, and phenylalanine. And we apply this diet in CKD mice, and we measure the renal fibrosis. And as you can see on the left, we decrease the renal fibrosis, so the progression of kidney dysfunction are reduced in mice under low protein diet, and also in mice under reduction only of aromatic amino acid. And it is associated with a reduction of the production of the main uremic toxin like endoxine sulfate and pecresyl sulfate. But in the other way, in other teams, increase only 2 amino acids, methionine and cysteine, and they apply this diet in CKD mice, and they observe that the increase only methionine and cysteine is able to protect the kidney. And they demonstrate that these amino acids are able to modify the activity of one key enzyme in the gut microbiota. They could reduce the activity of the tryptophanase, and the tryptophanase reduce, it's induce a reduction of production of endoxine sulfate and at least reduce the progression of CKD. So I think it's just experimental data, but it is very interesting to think that it's not maybe reduction of all protein could give a protection of the kidney, but maybe the reduction of some amino acid and the increase on the other. Of course, we need to go to the human to confirm this result. So now I give you some elements about the protein. I would like to give you some elements about fibers. We need to increase the fibers for the patient, and for this, we need to increase the food of plant origin. And what is very important, I told you that the protein could be toxic, but the fibers could be very beneficial for the CKD patient, because fibers can be metabolized by the gut microbiota in different beneficial metabolites, such the short fatty acid chains. We can, for example, the butyrate and the propionate. And butyrate, propionate are very beneficial for cardiovascular system. There are some molecules with anti-inflammatory property and probably reduce the progression of CKD. So, and instead, in the observational study, we observe that high level of fiber intake is associated with a low mortality in CKD patients. The plant-based diet have a lot of beneficial effect for the CKD patient. Of course, increase the fiber, but also increase organic base and inorganic base. And this increase have so consequence to decrease metabolic acidosis, to modify vascular systems, and all of this could prevent the metabolic complication associated with CKD and preserve GFR. But which kind of plant-based diet what should apply for a CKD patient? There are a lot of type of diet. We can have a DASH diet, Mediterranean diet, flexitarian diet. It's complicated, in my opinion. And I think that when we look at the composition of this diet, one thing it's what we observe in all this type of diet is you increase the fruits and vegetables and you reduce the meat. And we don't have evidence that one diet is better than the other, but I think the message is you increase fruits and vegetables, you increase fibers, and you decrease meat. I just give you some elements about the impact of this type of a plant-based diet of a nephroprotection. For example, in this study, the probability to be in dialysis is reduced when you have a good adherence for the DASH diet. Also, if you have a good adherence of a Mediterranean diet and you increase the vegetables, for example, it's associated with a reduction of kidney disease progression. Similarly, in this large study, they measured the incidence of CKD and the GFR decline based on the dietary profile. And as you can see, the patient with the overall plant-based diet have a reduction of the incidence of CKD and a reduction of the GFR decline. But one other point I think it's very important for the quality of life of patient is when you increase fiber, you increase you improve your intestinal transit. And the constipation is really a big problem for the CKD patient. And there are some observational studies that demonstrate that the constipation is associated with an increase of the mortality and the incidence of dialysis. So at least increased fiber could have different beneficial impact, but of course could improve the intestinal transit, and for the quality of life of patient, I think it's a very important point. So I think I give you some elements about fiber, about food or plant-based diet, but the next question is, what about the potassium? If you increase the fruits and you increase the vegetables, you maybe increase the risk of hyperkalemia for your patient. I would like just to keep a few minutes about this problem. I think we not be afraid by hyperkalemia, and also there are no evidence that the potassium that you eat is directly correlated with the level of your plasma potassium. And for example, in these two studies, in non-dialysis patients, there are no correlation between the concentration of potassium in the blood and the quantity of potassium that you eat. And I think maybe the potassium is more a friend than a foe. And for example, you know, these two study, of course, it's in general population, but the increase of the potassium excretion in urine, and when you supplement patient with potassium, you decrease the mortality and you decrease the cardiovascular events. The mechanisms, I don't have the time to develop this, but it's probably by the phenomenon that you call potassium switch. And high dietary potassium decrease salt sensitivity and maybe reduce the cardiovascular events and mortality. And in CKD patients, there are some data, and the high potassium excretion is frequently in all the studies associated with a better kidney outcome. I think we should not have afraid about the increase of the fruits and vegetables. I would like just to open the discussion that diet is not only the food. There are also a lot of things around the food. The food can be processed. We can give some supplement, some biotic, and also in the environment. And actually, we don't have a lot of study to study and to give some element about the impact of the biotic, processed food, and environment on the CKD progression, but also on the gut microbiota composition. And I think now we should more understand and decipher how the probiotic the supplement have an impact of the CKD progression and the gut microbiota composition. I just will give you some elements. For example, is in the Korean study, they measure if CKD patients have a lot of dietary supplements. And as you can see, many of the CKD patients have supplementation. There are majority vitamin and mineral supplementation. Some have a protein supplementation, a medicine, herbal, or whatever. In this study, they didn't see a very huge impact of this supplementary of the CKD progression, but of course, this study must be consolidated. Also, for the ultra-processed foods, I think it's a very hot topic, and we need to focus about this, the impact of this type of food. I just want to show you one study that demonstrates that when you increase the ultra-processed foods, when you intake more ultra-processed food, you increase the risk of incidence of CKD. In our group, we try to study the impact of the probiotic, and in the French cohort CKD, we measure the inflammatory parameter depending on consumption of yogurt and probiotic. And clearly, we observe a decrease of inflammation when you eat more probiotic and yogurt. So it's only the beginning, but I think it will be very important to study the impact. Several compounds of the diet are important for preventing the progression of CKD. The impact of the industrial diet and supplement diet must be considered, and I want to fighting the misconception, not counting bag of vegetables and fruits to reduce the incidence of hyperkalemia. And the nutrition also is not only the diet, it's also a lifestyle. And when you modify the nutrition of your patient, don't forget that you should modify physical activity, provide some advice about reduction of tobacco consumption, reduction of sodium, etc. And all this aspect, all this lifestyle modification could have a very good impact of the GFR decline or incidence in CKD. But the cornerstone of the nutrition is always the dietitian and the nutritionist. And we can do nothing if we don't have a good nutrition and dietitian in our unit. I think I want to focus on this point because in France we are very, not very good. And when we try to measure the frequency of a dietitian consultation in our CKD patient, we are not good. For example, in patients with stage 3, only 30% of CKD patients have a dietitian consultation, and in stage 5 is not very better. So we really need to increase the number of a dietitian and to increase to improve our way to provide some dietetic advice for the patient. And for consequence, in France, for example, in this cohort, the mean protein intake in French CKD patient is around 1 gram per kilo. So we are very far from the recommendation. I hope this could change because, for example, in France, we changed our financing method. Now we receive an overall funding. We are not paid by act. We pay for the global. For one patient, we receive some money, and we must do all the consultation what we think need. And to have this overall funding, we must propose a dietitian consultation for the patient, plus nephrologist consultation, plus the nurse consultation. And I hope by this way we can improve the implementation of the nutrition guidelines. And we try to think about how we can propose a dietitian consultation. We propose different modality: flash consultation, just 10 minutes, virtual consultation, e-consultation, or traditional consultation. And of course, we propose an educational therapeutic program. And just to be at the end, modify the nutrition takes time, and we must be patient, and we must be doing step by step because it takes a long time to go to the goal what we expect. So no nutritional advice without dietitian, and we need to think about different modality to provide nutritional advice. I still optimist because our society changed and we decrease our global consumption of meat. The gluten-free, the vegan is very famous for the moment, and I hope it could be a very good opportunity for our patient to follow the recommendation. So my take-home message, it's the nutrition is more just diet, it's a lifestyle, and we could educate our patient in this way. Of course, there are a lot of things we need to understand, and we need to go to the evidence-based medicine to must be support this data. And I think the term protein restriction, I think it's a bad word, and I think we should use a plant-based diet with a positive term. And nutrition targeting many aspects, quality of life, intestinal microbiota, vitamin, etc. And it's a very good way to improve the outcome of a patient. And don't forget physical activity. And just I like this editorial to suggest that food is a very good medicine. And for my last slide, I would like just to share you this picture to see the lifestyle, the nutrition, the very long road, and with this road we can improve the CKD outcome. So thank you for your attention, and I thank all my collaborators, and it's now open for the discussion.
Thank you very much, Dr. Koppe, for the excellent presentation. And now I give you the speech to the panelists, Professor Bakker and Professor Davenport.
Interesting talk, Laetitia. So in my part of London, we have obviously different ethnic populations. And so one of the populations we have are people who've come from a particular part of India who have a vegetarian-based diet. And although you showed a picture of a very physically fit young man, when we look at body composition, we find that our South Asian patients who are vegetarian have low muscle mass. And we often start them on dialysis with what would appear to be very low serum creatinines compared to, say, our Northern Europeans and our Africans and Afro-Caribbeans. And I agree, when we measure things like indoxyl sulfate and p-cresol sulfate, they're lower in our vegetarians. They have lower serum advanced glycosylation end products, and they have lower levels of these in their skin. So if you're thinking of moving towards a more vegetarian-based diet, in terms of what would you recommend to obviously make sure that patients are actually eating enough protein? Because there is this issue in terms of not all vegetarian meals contain the same amount of protein.
So, if I understand your question, you means that in patients with already in vegetarian diet, how we can do to improve? If I understand well. So yes, of course. That I think if patients are really in are already in the low protein diet, I think we don't change the way they are, and maybe we can try to increase other parameters like increased fiber, try to find some vegetables that are more increasing maybe tryptophan, tyrosine, and less in other. But I think yes, it's difficult to modify if they are in the good target. Maybe I am not answer very well question.
But I think the other issue with the increased vegetarian diet is that you get more binding of phosphate, you get more binding of calcium. And so it's not just necessarily the change in the diet and the change in the biome, but there are also other effects in terms of the balance of some of the other electrolytes, and as you said, particularly acidosis, compared to a meat-based diet.
I agree. I think it's a simple view that I present, and I think we doesn't understand, and we don't have the global picture. And of course, chelator of phosphate and chelator of potassium have a really impact on the gut microbiota and the environment. Of course, I agree, but I think it's just we should in the future more understand the interconnection and to more focus our recommendation. I think it's true, but for the moment I think we have a very global vision, and maybe if we try to understand the balance and the regulator, we can provide some more specific advice. But yes, of course, there are a lot of confounding factor in this way.
I was wondering, also like your presentation very much, and I was particularly struck by the slide in which you mentioned that all a low protein diet does is to shrink the patient to the size of his kidneys. It was a phrase by Mr. Parsons was mentioned in that slide. And I was wondering, how do you feel about that? Could it indeed be that if you have a low protein diet, that it is inducing low muscle mass, and that it is seeming that you protect the kidneys rather than that it's actually protecting the kidneys?
So, can you repeat your question, please?
And that the low protein diet is just inducing low muscle mass and provoking thereby a seemingly good kidney function.
Yes, but if I understand well, you mean that the low protein diet have a consequence of muscle mass. You mean?
Yeah.
Yeah. Of course, if you applied very low protein diet, maybe a very long time, we can suppose that we decrease the muscle mass, but in the different cohorts that we observed, we didn't observe a decrease of the muscle mass. And I think first because we maintain the calorie intake, and secondly because we supplement patient with a Ceto analog if we go very deep. And I think it's not what we observe, and of course we're monitoring patient very frequently to be sure that there are no modification of the muscle mass. And for example, in our unit, we perform at least an implantometry, maybe 1 or 2 per year in patient under low protein, and especially patient under very low protein diet. And also the problem that we observe is when we reduce protein intake in the beginning, the patient wants to be very good. They want to be the perfect student, and they decrease more than the protein. They decrease the calorie intake, and usually it's the problem of calorie and not the problem of the protein that we observe. And if we maintain the calorie, we maintain the glucid and the lipid intake, we have not a lot of problem in clinical practice.
And what about the methionine and cysteine? You showed that is that is protective, in fact,
Yeah.
and that is present more in meat, as I'm aware,
Yes,
than in plant-based foods.
Yeah, I think this study is really, for me, I know, a very interesting study, because it suggests that each amino acid have not the same impact in the kidney, and I think we need really to decipher which amino acid is toxic and which amino acid is not toxic. And in the future, maybe we can provide specific kidney food with very high cysteine and methionine and very low tryptophan tyrosine. Maybe for the CKD patient, it could not. It's maybe a dream, but for a dialysis patient, we can imagine that the supplementation for the patient who have the nutrition criteria, you can give some nutritional supplements specifically designed with this data for the patient. So maybe low tryptophan and high cysteine and methionine. It's my point of view and how we can go in this way. But I think it's only one study, and I think it should be challenging and should be confirmed in clinical in a CKD patient.
Yeah, so you think more studies are needed to guide patients towards a low protein diet even better than we can now do?
Yeah. Yes, it's a suggestion.
So there is a question by Dr. Natalia Shabalina. Thanks for the interesting lecture. What foods to recommend to patient in the pre-dialysis stage for energy?
For energy, the category recommendation suggests 25 kilocalorie, but in practical, it's difficult, I think, to obtain this calorie intake. Usually, the patients are lower, so it's really challenging, and we need to follow the patient to maintain 25 kilocalorie per day. I think we should follow the nutrition criteria, and for the patient, for me it's more important. We should monitor the body weight. We should monitor the appetite. We should monitor albumin. For me, is not a good marker, but we should monitor the muscle mass and fat mass, for example. The hand grip, it could be easy, and by this criteria, it's a good way to see if the calorie intake is sufficient for patient. But at least we need to really maintain a high calorie intake to fight the denutrition that is very frequent in pre-dialysis patient, especially in late stage, and more in dialysis patient.
Yeah, I agree. Are there other questions from the panelists? So there is another question. What is the gold standard in nutritional assessment?
It's a good question. But I try to find in the literature what is a good assessment for nutrition. For the moment, we don't know. There are no evidence that one is better. For my opinion, the best way is the food recovery during 7 days. It's the best. It's very complete. But in practical, it's very difficult to have this. We should take a lot of time in patient to see to have an explication that we eat. I think it's difficult, but the 24 recalls is for me the most simply and the most useful tools. And of course, for the patient who in pre-dialysis patient, one of the useful tools is the 24-hour urine, and you can have a easy estimation of the protein intake and the potassium intake and the sodium intake. So, in my opinion, 24 recalls and 24 urine collection is the more easier clinical tools for to evaluate nutrition intake.
So I would agree that we think that the 24-hour food recall is good. We have problems when we ask patients to take books home and record what they've eaten over 3 days or longer. So we find patient participation falls off, and that's difficult.
Yeah.
And I think the other issues are that 24-hour urine collections are good when patients have low levels, at lower levels of CKD stage. But the problem is, of course, is as the CKD stage progresses, the amount of urea, sodium, potassium obviously falls in the urine. So what it's good at is spotting somebody who's eating too much sodium or eating obviously too much protein, because suddenly you find there are quite high levels of urea or high levels of sodium in the urine. And in terms of things like DEXAs and bioimpedance, if patients are volume overloaded, then they will overinterpret muscle mass. And so one of the issues, again, is volume status of patients when you're doing scans, etc. That has to be considered.
I agree there are no perfect model. I agree it's really, but I think the nutrition is complicated, and if we want to have some practical tools, I think we need to find a compromise. Of course, we need to know what is the limit that we have, but I think my objective is that the nutrition could be used to be easy to monitor and easy to apply, and that's why. But I agree about the limit that you mentioned.
Yeah, I agree. 24-hour urine is an important source of information, of course, particularly in patients who are subjected already for a long time to dietary advices. They will tend to give socially desirable answers, and then you can see the excesses exhibiting themselves from 24-hour urine, which is unbiased.
Yeah. I agree, but yes, but maybe we can in the future. Maybe we have some modern tools. Maybe some for example, I have a collaborator. We work on the intelligent artificial network in Bayesian network to maybe try some different argument to estimate the nutrition intake. Maybe we should have new tools in the future, but for the moment, it's like that.
So there is another question. Usually salt restriction we take by nephrologist is 1.5 to 2,000 of salt per day, unless we have patient with severe albuminuria. With normal blood pressure, we go hypotensive afterwards. What should be the solution for salt?
I think it's a complicated question. I am not sure I have the answer, but I think the hypotension is maybe not related to the low salt intake, and maybe we should see what there are maybe other problems. And I think the low salt is clearly there are a relation between the salt intake and the mortality and cardiovascular impact. So I suggest to not increase the salt and try to find why there are so hypotension, and maybe it's not the salt. It's like the potassium, for my opinion. The vegetables and fruits is not only the cause of hyperkalemia.
Yes, I mean, I would agree. We try and strive very hard to restrict sodium in all our patients. But there are some patients, so if you have patients like with Gitelman's syndrome, etc., then they will be hypotensive. And when you do sodium MRIs, you can't find the sodium in the muscle, etc. So we know from some old studies going back to the 1950s that sodium will go into the vascular smooth muscle, and so it'll increase tone in blood vessels. So I think you go back to, as Laetitia says, is why is the patient hypotensive? So you've got the tone in the vessel wall, and obviously if you totally remove all the sodium, then there will be reduced tone in the vessel wall. But then the other issue is, what about the viscosity of the blood? So you've got, if you imagine the pressure on the inside of the blood vessel, so that's the volume. So the first thing you ask yourself in somebody who's nephrotic, who is hypotensive, is, have I got the volume status right? Have I actually sort of taken away too much fluid from the patient? Question one. And then obviously the viscosity will be related to the hematocrit, the albumin concentration, and yes, the serum sodium. So the issue would be is to see what the serum sodium is and get an idea of volume status. But even so, I still would want to restrict sodium. I wouldn't want to give these patients sodium back.
Yeah, thank you for this explanation.
So in your talk, you suggested to have a nutritionist. And the other point is important, is to convince our patients about the utility of this kind of approach. I think that these are two important points. The nutritionist and convince the patient, so the adherence of the patient to our prescription of diet.
Yeah, I think it's important that if we are not convincing of a medical or a dietitian are not convincing, how we can convince our patient? I think it's the first way, and we should be several professionals involved in nutrition to convince patient. If you have a nutrition very convincing and the doctor not, how it can work? And it's sometimes like that, and I think it's important to have a very good discussion with your dietitian to go in the good way. And I think it's basic, but I think it's the cornerstone on the nutrition. If you don't have some, because it's difficult to apply the guidelines, it's difficult to move the nutrition habit of a patient, and especially in a chronic disease. So if you are not convincing by yourself, and if your dietitian are not convincing, but also your nurse, also your every partner in the patient, I think it's difficult. But if at each time of the pathway of a patient, when you take care of a patient, if every time you speak about nutrition, it could be easier. For example, I asked to my secretary when she introduced the patient. She asked, "Oh, how are you? And do you have a good appetite?" Just this question. Do you have a good appetite? It's the first step to detect nutrition disorders. And if a patient says, "Oh, I'm disgusted, I'm not good," I think it's an alarm to say, okay, the nutrition could have. And it's for the nutrition, but for the guidelines we can have. So how do you respect the following guidelines, like that? And at each step, I think it's important.
So I think the issue for us is that although the university has nutrition courses for students at both undergraduate and postgraduate level, there's very little nutrition actually taught in the medical school. So a lot of our doctors know not very much about diets and can give proper advice to patients. And so I therefore feel there is a very important role. And we've published a couple of studies in the past where we've had dietitians go in and, if you imagine, give intense teaching to patients. And over a 3-month period, yes, you can follow the chemistries and see that they've improved and they've followed the advice. And then, of course, we run out of money, so study ends. And then you say, well, okay, what happens after 6 months, 9 months? And we find everything goes back to where it was before. So the answer, I think, is that yes, I think it's very important that we do have access to dietitians, nutritionists, but they need to keep coming back. And just as we as doctors will see patients on a repeat in the clinic, they again need to have repeat contact with them.
I agree, and I think it's a very, very important point, and we negligate, we think it's not important, but I think it's it's very, very important, this point.
In one of your first slides, you showed that that we have drugs, renal protective, so ACE inhibitors, ARBs, now SGLT2 inhibitors, and then there is diet. The SGLT2 inhibitors came relatively recently. Do you think the dietary advices have to be modified after having these drugs having been introduced?
It's a good question. I think, of course, we have a lot of chance to have this therapeutic, and of course it's very powerful therapeutic to prevent the GFR degradation. It's clear, and I think it's easier to take 1 pill per day with not a lot of symptoms compared to modify all your lifestyle. And I agree, and maybe the nutrition have not so important impact that before, because we have this drug. But I think 2 things. First, we don't know if we don't have a synergic effect of the nutrition and this drug, and maybe it's like the inhibitor of enzyme, the blocker of the renin-angiotensin system, if they work less if you have a high level of sodium intake. So maybe, we don't know, we don't have the data, but maybe the glyphosine have less impact if you have a type of diet. I imagine, we don't have some data, but we can imagine. But at least if it's not synergic, it's additive. And maybe if the nutrition provide some couple of months to protect the kidney for the patient, is not nothing. It's very important to delay the dialysis for 6 months, for 1 year. I think it's not nothing. It's important for the patient. So maybe it's have a less impact of the new drugs, but for me, it's still important. And I think in the future, we really need to understand the synergic effect and the associative effect between this drug and the diet.
Yeah, that's it could well be that the scene is being set again in a whole other direction by the combination of these drugs, of course. Yeah. And another question is about the dialysis. Do you usually you give a higher protein diet when you are on dialysis? You didn't mention so much on it in your presentation. Do you have special thoughts on that?
Yeah, I couldn't speak about different all of the points. So yes, in dialysis, you have a catabolic situation very intense, and so we recommend to increase the protein intake to 1.2 grams per kilo per day. And it's different situation, and we not do decrease the protein intake in dialysis patient. But if we want to have some in the future, I think maybe that we discussed before, maybe we can supplement patient with protein if we have some nutrition criteria with specific nutritional complement, with maybe without precursor of some rheumatic toxin like tryptophan, with the supplement with low tryptophan, so you can imagine that it reduces the production of endoxy sulfate that could not be well removed by a dialysis technique. So we increase the protein, of sure, but maybe we need to think which type of protein we should increase in this patient. But for the moment, we have no data, just hypothesis.
Mm-hmm. So you've raised a very important point there, Stephan, that what you've got is we're now with a newer generation of dialyzers. So certainly in Western Europe, you've got one group who've gone down the route of hemodiafiltration, and the others are possibly looking at some of these so-called middle cutoff dialyzers. And both these systems will remove some small, higher number of small molecular weight proteins. So we are going to see more protein loss over time with this new generation of, say, of dialyzers and widespread introduction of certainly high volume HDF. So that is an issue. And certainly when we've recently looked at protein intake in our dialysis patients, and about 60% of our patients don't meet recommended targets. And when I say recommended targets, these were targets based on doing ordinary, like high flux dialysis, 5 or 6 years ago. So there is an issue in terms of nutrition in our dialysis patients. I think that's also why we're so-called seeing this, where we have these patients where they lose lean body mass and gain fat weight. And I think the issue is that we probably aren't feeding patients enough. And then you have the situation of, you have some countries like Mexico, where they do not feed patients whilst on dialysis. And you have other countries that will give patients a meal when they turn up for dialysis.
Mm-hmm.
And I think this is an interesting issue in terms of, should we feed patients, or is it up to the patient to bring in their own food? These are the questions, because obviously, when somebody comes up for dialysis, they may have taken an hour, half an hour, an hour to get to the dialysis unit. They could be there for 4.5, 5 hours, another hour or so to get home. So
not eating anything,
isn't it?
Yeah.
It's yes, you are right, and we have a big problem during COVID period, and we stop the collation, the nutrition during the dialysis, and we are very big issue on nutritional parameters, and we see a decrease of the nutritional parameter because we stop the capacity to eat during dialysis session during COVID period. So I agree. I think it's important to feed our patient, and to probably we not feed enough. And in hemodial filtration, it's also another problem.
So, if there are no any questions, I would like to thank you very much, Dr. Koppe, and all the panelists, Professor Bakker, Professor Davenport, for this very interesting e-webinar.